Okay, today I'm going to go over an atraumatic crustal sinus lift using the Versa drill and PRF. I like to use the Versa drill because it densifies the bone and actually will help me split and spread the bone so that I get more bone around my implant, and it also will assist me in lifting the floor of the sinus. PRF also as an alternative to an autogenous bone graft because of its growth factor properties. My first incision here is going to be a simple envelope flap with no releasing incision is necessary. Tough tissue here. So what we can see is we have a very narrow ridge at the crest, and so that's really when the Versa comes into play. So here I've lined up my osteotomy. I go 5 millimeters distal of that last bicuspid so that I'm in the center of my future molar tooth. From there, I'm going to use the first drill on the Versa in reverse at 400 RPMs. And I'm going to go about to where I think the floor of the sinus actually is. Measuring on the CT scan, it's anywhere between 6 and 8 millimeters in the mouth. Here I'm about 8 millimeters. So here's our check film. You can see I'm about 1 millimeter or 2 short of the sinus, and that's okay. We don't want to use that first drill to go and break the floor of the sinus. As we go, still using a very pumping motion, making our osteotomy bigger. But you can see how the osteotomy is spreading and the bone is actually densifying as compared to the traditional approaches where we're removing bone. With these particular drills, and when we put them on reverse, they have a very nice effect of osteodensification. As you go, getting plenty of resistance at the floor, but you will see as I get through the floor of the sinus, I'm going to use a drill no smaller than a 3.0. In fact, I think I'm going to use about a 3.4 to break the floor of the sinus here. As long as you have not penetrated the floor of the sinus to the membrane, using suction is just okay. It's fine. Once again, 3.0 or 3.4 drill here, and we're going in reverse, and you'll see when we finally are able to penetrate through that through that floor of the sinus, which happens to be cortical bone as well, so it is definitely dense. And it looks like we got through right there. Yeah, you could see we have less resistance. So now we're going to take a traditional osteotome. We will not be using a mallet, but the osteotome is a nice condensing tool. We have to fit the proper osteotome to the osteotomy site. We're going to take our PRF, which is can be quite difficult to handle if you haven't used it before. But this is a sample that we draw from our patient that's enriched with 96% platelets, which have all the growth factors for regenerating bone or regenerating pretty much anything in the body. And you can see my osteotome looks to be a little bit too big, so I went to a smaller size. And I'm just going to gently condense the PRF into the osteotomy. And I'm going to push it, slowly elevating the membrane of the sinus, the Schneiderian membrane. And the first one, it's a little bit tighter, so you can see I'm getting plenty of resistance, but because I'm not putting any kind of pressure on that membrane, I'm just using something soft and gently pushing it, it atraumatically lifts with the help of the Versa drill, breaking that floor of the sinus initially. I like to use the PRF. I don't need to use particulate bone, actually, as long as you don't have a too large of a perforation into the sinus, into the Schneiderian membrane. You're going to have so much blood flow that pretty much you can pack anything you want into the sinus, and you will get good bone. There's actually been, the literature's actually showing that you can actually put the implant in there without an allograft or PRF or anything really, because with that blood flow there will be a new cortical plate that forms around the head of your implant over time. But if we want a little bit more bone around the apex of the implant, we're going to use some sort of grafting material. As you can see, we're getting to the second PRF, and that's a lot easier to get into the osteotomy and get into the sinus itself. In this particular case, I really only want anywhere from 2 to 4 millimeters of elevation, because my final implant is going to be a 5 by 10 AnyRidge Megagen implant. It's a very versatile implant with many different sizes and many different healing cap sizes. So and very aggressive thread. So I love the stability that we get, and I love the ability to use a big healing cap, especially in situations like this.
It's easier for me because I can put it out of my own way, you know. Okay.
All right, so if we use on a very slow setting and a slow pumping setting, never past 2 millimeters past the floor of the sinus, we can actually condense the PRF with our Versa drill and just kind of pushing it up into the sinus a little bit more, creating a little more space. And this will be the last PRF that we end up using. A lot of serum coming from the PRF. That's platelet, poor plasma kind of coming out of it. Go ahead and go real slow, and just slow pumping motion with our osteotomy drill, just to make sure we got everything up there. Again, it's very important. You don't want to go much more than 1 to 2 millimeters past what you think the floor of the sinus is with the drill. This now we're going to place our implant. One of the nice features of this implant as well is the second thread down is actually the widest, which makes it a subcrestal implant. So we want to go all the way to the crest at the very least, and preferably a 0.5 millimeter to 1 millimeter below the crest, and we still get really nice results. We know that perioimplantitis happens really at the top of any rough surface, so that implant we most certainly want to be under the crest, so no plaque or bacteria can stick to it. In this case, I want to torque this implant down and and make sure I get really wonderful primary stability. You can see we locked out at 50 Newton centimeters with our implant drill. So we know we're really stable. I'm not worried about pressure necrosis. As we know, pressure necrosis is a concept that we get crestal bone loss because of the cortical plate at the head of the implant due to the lack of blood flow. So in this particular case, we can torque away and not worry. And once again, now we're going to get that down below the crest. Make sure I'm happy with that, where the head of the implant it actually is. We want 2 millimeters of bone on all aspects of the implant, so that we ensure that we get proper blood flow to the bone, and we minimize the chances of bone loss. So I'm pretty happy with that. Looks like now I'm going to go ahead and put a 5x3 healing cap there, so we know that we'll have a decent profile, emergence profile when everything heals. We'll just unscrew that and take a quick impression. Solution to pollution is dilution, so we irrigate all surgery. And there's our final result. You can see that nice little elevation, and thanks for joining me.